it's fashionable to show where we work, so that's where I work, and that's the only modern building in Birmingham. Everything else is 500 years old, so this is the only modern building. My disclosures, nothing really relevant to this talk. The outline. So because we're going to be talking about obesity, I thought it's only important that we, and pertinent that we actually start off with the definition of obesity. We'll then talk about some epidemiology, talk about outcomes of obese donors, then we'll move on to available options for obese donors, and I've also got a clinical scenario in the end, and then I'll give you my verdict on what we think we should be doing. So as you probably know, we are in the midst of a obesity epidemic, and as this cartoon shows, it is widespread. So it's widespread all parts of the world, and India or the UK are not the only countries, and I'll show you some data for this. This is a few years old, however, it does show that many parts of the world are actually going through an obesity epidemic. And we're likely to see this for the next 20, 30 years until certain public health interventions take place and then change the trajectory. So the obesity grading or classification by the World Health Organization divides it into 3 groups. So less than 25 is ideal, between 25 to 30 is grade 1 or overweight, 30 and above is grade 2 or obesity, and grade 3 is morbid obesity where it's more than 40 BMI. This is data showing the prevalence of obesity in India. So as you can see, it's about 25%, both men and women, and there's really no difference between the two sexes other than maybe perhaps it's a bit more prevalent in women. So what do the guidelines actually say about obese donors? Let's start off with the UK. As you probably know, I'm a little biased. So the UK guidelines published in 2018 show or say that overweight patients, that is BMI between 25 to 30, can safely proceed to donation, but the moderately obese ones between 30 to 35 must be counseled, and if the donor is more than 35, donation should be discouraged. The European guidelines actually say over 35 is a contraindication. And the KDIGO guidelines have actually a little bit more vague. What they say is if it's over 30, the risk should be individualized. And I think the reason for the KDIGO adopting this kind of a stance is because in the US, as you probably know, it's a private healthcare system. Centers tend to do their own thing, so they don't want to dictate what centers should do. And hence, they've just said, if it's more than 30, then we advise some caution. I only put this up only because it's a recent one, and I thought the Spanish guidelines, they may have taken into consideration some recent data on obese donors and perhaps would have been a little less cautious, but it appears not. So again, they say if its BMI is more than 35, they advise caution, and in fact they say that if the patient is obese and have got a secondary risk factor such as hypertension or dyslipidemia, then you should consider not for donation. And more than 30, again, they're saying it's a relative contraindication. So why the caution? And I've shown you that all the different guidelines are saying different things. Mostly, if it's over 35, they'll advise caution or contraindication, and if it's between 30 to 35, they think it's okay. So why the caution? So let's actually start talking about obesity in the general population first, and then we'll move on to donors. So it shouldn't come as a surprise that if you're obese, you're 5 times likely to develop hypertension, 2 times likely to develop diabetes and metabolic syndrome. So if someone is obese, likely to develop hypertension, likely to develop diabetes and metabolic syndrome. And this is in the general population. Again, what this slide shows is between males and females, there really isn't, there is some difference, and at 30 to 35, the median survival is reduced by 2 to 4 years, and between 40 to 45, it's reduced by 8 to 10 years. So people who are obese live less longer than people who are less obese, and it's actually comparable to the effects of smoking. So obesity, or at least morbid obesity, is equivalent to the effects of smoking. And what this shows is if the patients are obese and have a cancer, their risk is exponential. So if they've got, say, throat cancer, and if they've got vascular disease, then the risk is exponential, both in males and females. So let's now move on to obese donors, and let's see what the outcome is if an obese donor decides to donate, what actually happens. So this is some short term data or short outcome data. So it's looking at pre-operative and post-operative GFR. So on the left, so between the different BMI groups, the pre-op GFR corrected for body surface area is about 100 mil, and post-operatively it's actually pretty similar. So even the group over 35, the GFR dip after operation or after donation is actually pretty similar between all the groups. So why the caution? So at 6 to 12 months after donation, the short-term outcomes seem acceptable. So it's not just the renal function, but also the proteinuria. So there was no change in proteinuria, no change in GFR between the different groups. Bear in mind that this is short-term data between 6 to 12 months. Now this is an interesting study, an important study. So this is from Minnesota, from Raja Kandasami's group, showing 3,500 donors, actually 3,700 donors, of which 650 were actually obese donors. So when they took, when they did a retrospective analysis and studied the outcome of donors over 30, 40 years, between the two groups, i.e. less than 30 and over 30, no difference. So if the donors were less than 30 or over 30, in terms of the GFR, there really wasn't any difference between the two groups. And this is single center, but 650 donors. A few more slides on outcome data. Again, this is another single center study looking at 200 donors. Again, if the patients were between 35, 40 or less, the GFR dip after donation is actually pretty similar. It's along the regression line. So there really isn't any difference in GFR between the groups. From the same study, again, over time. So if you look at 4, 6, 8, 10 years, the different BMI groups, there really isn't any much difference in the GFR trend over time. So I know this study, or actually this slide looks a little busy, but what I'd like to point out is, once again, if you just look at single center studies, short-term outcomes, less than 30 or greater than 30, in terms of the BMI, there really isn't any difference. But this study actually looked at the subgroup more than 35, and even in the subgroup more than 35, there really wasn't any difference in the number of patients developing a GFR less than 60 after donation, and the p-value was not significant. But having said that, I think this is, on the contrary, showing an opposite trend. So this is from Jamie Locke, a large study. So this is 120,000 patients, live donors in the US, registry data showing obese donors were likely African or Afro-Caribbean, had hypertension, and the estimated risk at 20 years was 93.9 per 10,000 donors. So quite different to what I've shown you in the last few slides. So in the last few slides I showed that there really wasn't any change in GFR, but this one, if you look after 5-10 years, there's a big separation in the lines. So the top line is patients who are obese, and the bottom line non-obese. So if you're obese, you're very likely to develop end-stage renal disease. And this is 120,000 patients. The same study, so what this one is showing, that it's not just end-stage renal disease, you're also likely to die earlier than patients who are less obese. So patients who are obese are likely to die earlier than those who are not obese. Let's move on to surgical complications. We've looked at the outcomes in terms of GFR and proteinuria. Let's look at surgical complications. So what actually happens if an obese donor decides to donate, and what can we expect in terms of surgical complications? Single center study, and then I'll show you another larger study, but what it essentially shows is patients who are obese had a longer operative time, approximately about 19 minutes, minor perioperative complications, either they can develop wound infections or hernia, but low rates of major complications. So the conversion from a laparoscopic nephrectomy to an open nephrectomy, the rates are the same. And also if you look at the length of stay, rates are the same. So it's only the minor complication rate which is slightly higher, but the major complication rate, there's no change. And there's a slight increase in warm ischemia, which I should mention. Again, this is just a larger study showing the same thing. So it shows that if patients underwent laparoscopic donor nephrectomy, it's an increasingly safe procedure, and this is in about 80,000 living donors over a 15-year period. There really wasn't any increase in surgical mortality. So it's pretty safe procedure even in obese donors. And I think with robotics now, surgeons are opting to do robotic donor nephrectomies, the rate's going to be quite small of minor complications. So let's just recap what I've shown you so far. I've talked to you about the obesity epidemic. All countries are being affected. It's very likely that the next person you see for your recipient is someone who's going to be obese, maybe 35 or 40 BMI, who wants to donate, husband to wife or vice versa, or a parent to a child. Guidelines vary in the advice, but high risk and caution advised in donors above BMI 35. And we've talked about the different medical and surgical complications in these donors. And I've also said that in surgical complications, the rate of minor complications is slightly higher, but major complication remains low. So what are the options? What can we actually do if a donor comes forward and they want to donate and they are actually obese? What options do we actually have? In my view, there are three options. Weight loss, either they can be supervised, or they can have bariatric surgery, or pharmacotherapy. And we'll also talk a little bit about the surgical technique, what we should be doing, or what the surgeon should be doing. First of all, let's talk about weight loss. So how many times have we seen obese donors, regardless of the BMI 30, 35, or even over 40, and then we say, thank you for coming forward, but we'd like you to lose some weight. I'll give you 3-6 months. Here's a sheet of paper. Please go and try and lose like 100 kilos and come back in 6 months, and then we'll accept you. It just doesn't work. It just doesn't work. I've seen personally, so many donors who come forward, they're obese. We just give them a sheet of paper and say, please lose some weight and come back in 3-6 months. It just doesn't work. And this study just shows that. So if you looked at the number of patients who actually ended up losing weight, was only 13%. And this was actually supervised weight loss. It's not just a sheet of paper. Patients actually had telephone consultations with a dietitian. They had supervised exercise programs. And regardless of what intervention they had, only 13% actually managed to lose weight and eventually donate. So lose weight meaning get to a BMI of less than 35. So it just doesn't work. And even if they do lose weight and donate, they just put it back on. And that's what this study is showing. So in all the three groups, if you look at the slides here in the middle, so they put on 5 kilos over time, 5 kilos, again another 5 kilos, and the BMI just goes up. Yes, they lose weight because they want to donate, and after they donate, they just put weight back on. Nothing's really stopping them from putting the weight back on, and then developing all of those cardiovascular complications we talked about: hypertension, diabetes, metabolic syndrome, and dyslipidemia, and so forth. So is bariatric surgery an option? Can we do this? Is it actually sensible to direct our potential donors towards bariatric surgery? To answer this question, let's look at what happens in non-donors, in the general population, when they have bariatric surgery. So they lose a lot of weight. So they lose about 49 to 50%. And it's sustained, and I think I've underlined that because the weight loss is sustained at 5 years. And not just that, look at the comorbidity remission rates. Diabetes remission, 12 to 62%. Hypertension, nearly a third, at least 30 to 60%. Dyslipidemia, all of these cardiovascular risk factors get better. So they lose weight and the remission of all the cardiovascular risk factors. And if it's de novo, meaning they don't have bariatric surgery, but patients, if they try to lose weight supervised or unsupervised, whatever it may be, none. Diabetes remission, hardly anything. Hypertension, nothing really to talk about. Dyslipidemia, nothing to really talk about. So it seems like bariatric surgery, at least in the general population, seems like a good idea. So is there any data in donors? So this is going back to about 2009 in Brazil. So Branco actually decided to perform bariatric surgery in 2 patients who came forward for donation, and he showed that the post-operative outcome was quite good. They eventually went on to donate, and the BMI reduced. And then in Australia, in 2012, they actually did a gastric banding for a donor who'd come forward, and they lost about 54%. So the weight or BMI went down from 41 to 32. This is actually quite a recent study trying to answer this question. There were a few other studies which I haven't shown, but the data is only accumulating about bariatric surgery because it's a new thing. We're trying to gain confidence in doing bariatric surgery in potential donors. So one other study which I haven't shown is from New York, where they looked at 22 donors who had bariatric surgery historically for some other reason, but then later on at a different time point decided to donate. So they looked at a historical cohort in those 22 patients, and over 20-year period, they all went on to donate safely. No cardiovascular risk factors, good GFR, post-operatively good GFR. And this is the first prospective study from Israel last year in March. So there were 2 control groups. The first control group is bariatric surgery alone, about 46 patients. And another control group was patients who are not obese and decided to donate. And the middle group is actually patients who were obese, wanted to donate, and underwent bariatric surgery and eventually donated. And if you look at the outcomes, similar weight loss between bariatric surgery and patients who donated, similar weight loss. And except the study group had slightly worse lipid profile, so they were hyperlipidemic. And if you look at the donors, the 2 groups, which is the non-obese and the obese, similar GFR and proteinuria after donation. This is short-term data, I appreciate that, but yet it still shows the safety of the procedure and the likelihood of doing a successful donation. Similar GFR, and the absolute GFR just reflects the weight loss and nephron loss, meaning in patients who were obese and eventually donated, the GFR was actually higher because there was a correction for their body surface area. But yet it says that there really wasn't a dip in GFR, and that's the important point. So which surgical procedure? As you probably know, there's quite a few. So what should we be recommending? Let's look at 2 major ones. The first is the Roux-en-Y versus the laparoscopic sleeve gastrectomy. And this study just shows the comparison between the 2 groups, that in terms of the weight loss, it's pretty similar. Whether they have Roux-en-Y bypass surgery or a laparoscopic sleeve gastrectomy, the difference in weight loss is pretty much the same. However, in terms of the complications, a laparoscopic sleeve gastrectomy would be preferable from a stone oxalate nephropathy perspective. So in terms of risk of complications after Roux-en-Y, it would be higher, and therefore we would recommend a laparoscopic sleeve gastrectomy. So what happens after patients undergo bariatric surgery and they want to donate? We would advise 6 to 12 months. So after they undergo bariatric surgery successfully, 6 to 12 months post-bariatric surgery, as long as they sustain weight loss and their BMI is less than 35 for at least 3 months, I think they should be safe to donate. But bear in mind about the risk of stone formation. They need to be counseled adequately. And also the other point is about donors who are coming forward to donate. They have to undergo additional surgical procedure. There are costs involved. There are ethical complications about them having to undergo a different procedure just to donate. So all of these things need to be borne in mind, and we need to discuss these risks with the potential donor. And obviously there's cost involved for the potential donor. What about pharmacotherapy? I only have 1 slide on this because there just isn't any data. So this is an opinion piece from Dori Segev, who I'm sure you know very well. He's now in New York because he's trying to do a lot of work with pig kidneys with Bob Montgomery. He was in Johns Hopkins, but he's moved to New York now. So this is an opinion piece from Dori Segev saying, we should be considering the GLP-1 analogs as weight loss management for potential living donors. So instead of sending them to weight loss management or to bariatric surgery, we should be talking about pharmacotherapy. So GLP-1 receptor agonist. So this is an opinion piece. I haven't used it. I don't know if any of you have used it, but certainly in the general population it seems to work. But my only concern with using pharmacotherapy is the sustained weight loss. We haven't seen sustained weight loss in potential donor, not just donor, I mean in general population. As soon as they stop the drug, it gets worse. And even when they're taking the drug, obviously there's a cost to the drug, but even when they're taking the drug, there really isn't sustained weight loss. And I think that's my concern with pharmacotherapy versus bariatric surgery, where you can actually see sustained weight loss. We've talked about the donors. So what actually happens if we take a kidney from an obese donor and give it to a recipient? Because you've got to look at both sides of the coin. It's unfair if we just look at the donors and their outcomes. It's also important to look at what happens to the recipient of those kidneys from obese donors. There is a slight concern because there's data showing increased risk of graft failure. And if you look at the different BMI graphs here, less than 20, 25, or 26 to 30, up to 35 and over 35, there's slightly higher risk of graft loss in the kidneys that are taken from obese donors. There's a number of hypothetical mechanisms, and we'll talk very briefly about that, but it's something that you need to bear in mind, and perhaps to counsel the recipient that, you're not getting a Rolls-Royce kidney, you're getting a kidney which may not last for, 20, 10, 15 years. It's likely to last a shorter amount of time. And just in terms of numbers, they experience higher risk of graft loss. For every 10 kg increase in BMI, the risk is about hazard ratio is about 1.1 to a 12% increase of graft loss. In terms of hypothetical mechanisms, so obese donors, it's a fatty kidney, and they can develop metabolic syndrome that can cause obviously hyperlipidemia, hypertension, insulin resistance, and all of these things causes increased oxidative stress and damage to tubules, the gloms and podocytes. And similarly, because of the increased adipose tissue, they have increased RAS activation, volume overload, hypertension, glomerular hyperfiltration, hypertrophy, and albuminuria. So I think these are all the different mechanisms that cause to early graft loss in the kidneys that are taken from obese donors. And also don't forget to bear in mind the increased warm ischemic time. We've talked about donors, we've talked about the recipients, and I'll just very briefly touch on obese recipients. What should we be doing in obese recipients? Again, we can certainly send them for weight loss, but I'm just showing you this because we published a systematic review. The reason for this systematic review was because we are trying to set up a high BMI service where patients come in and they have bariatric surgery and then they go on to the waiting list. And we wanted to answer the question, when should we be doing bariatric surgery? Should it be during CKD? Should it be after they've approached end-stage renal disease or on dialysis before going on to the wait list? Or should it be after transplantation? And all of those are important questions. And we feel, and we think, and based on our data, that it should be pre-listing. And the reason for that is because if they are obese, it's unlikely they're going to get onto the list, because centers are going to say, you're obese, there's high risk of cardiovascular mortality, please go lose weight, we're not going to put you on that list. But in fact, if they undergo bariatric surgery, diabetes may get better, hypertension may get better, their weight may be much lower, and they can access the waiting list. So it's likely that more patients can go onto the waiting list and then end up with a transplant. So we feel bariatric surgery should be done pre-waitlisting. I've got a clinical scenario, and we can have a show of hands and see where we are with this. So 72-year-old recipient on dialysis for 2 years, active on the disease donor wait list. Wife who's 70 years old, she's a willing, motivated donor. BMI is 42.2, has tried to lose weight, give a sheet of paper, go lose weight, hasn't worked over 6 months. A little bit actually. So BMI is 42 to 40. She's got a history of hypertension, which is well controlled on amlodipine and ramipril, so 2 drugs. Otherwise, workup is unremarkable. Measured GFR is 80 ml, corrected for body surface area. No hematuria, proteinuria, and no LVH on transthoracic echo. What would people do? Would you accept this person as a donor? Any show of hands? So I'm going to assume that no one wants to if you don't show your hands. Okay, I think there's someone who wants to. Right. I've put this up mainly to show you two things. One, there is a risk calculator. I'm sure you've probably seen this. The transplant models, if you Google this transplant models, there is a risk calculator that will tell you the lifetime risk. So if there is a donor, whether they are obese or not is a different question. But if you have a donor, it tells you before donation what the lifetime risk is of developing end-stage renal disease. So for this donor, particular donor, in the case scenario, I've put in all of those variables that I showed in the clinical scenario, except the fact that the race is white. There are only two options. It's either white or black. And my view is that Asians, such as myself, we fall in the middle category because we have data from the white Caucasian population from the US, and we have data from the Afro-Caribbeans, and we just don't have data about Asian ethnicity. So I think they lie somewhere in between the two big groups. The whites do better, the Afro-Caribbeans do worse in terms of end-stage renal disease, and I think the Asian ethnicity is somewhere in the middle. But if you look at the pre-donation lifetime risk, it's only 0.1%. So if this person donates, regardless of the BMI, regardless of the hypertension, the pre-donation lifetime risk is only 0.1%. And bear in mind, age is inversely proportional to your end-stage renal disease risk, which means if you're younger, the risk of end-stage renal disease is higher. And if you're older, the risk of end-stage renal disease is lower. The reason for that is because you've lived 70 years. What's going to happen in 10 years? Quite small. But if they're only 20 or 30 years old, they still have 50 years to live. So the risk of something happening in 50 years is higher. So for that reason, the risk is actually quite small in this person. It's only 0.1%. So I would certainly accept her as a donor. Last few slides, and I can see we're keeping to time. It just shows what we've discussed already. So bariatric surgery outcomes in the general population, I've already shown you this. And the recipient outcomes, you take a kidney from an obese donor, you give it to a recipient, there's a higher risk of graft loss. We need to bear that in mind. And what actually happens to the obese donor, we've talked about the differences in the different studies. So single center studies showing good outcomes, and large registry data showing high risk of kidney disease and higher mortality risk as well. And I've tried to answer this question myself. Why is that? And I think the reason for that is because if you look at the single center study, they're coming to one center, so they're just not disappearing. So the follow-up is likely to be better. So they're likely to handpick carefully selected donors. And if you look at larger population, you don't have a control about their follow-up. So I think that's the reason the single center studies actually show that it's the short-term outcomes are better. So this is my verdict. We've talked about the obesity epidemic. It's very likely that you might actually come across obese donors in your daily practice. And it's likely to get worse in the next 5, 10, 20 years. Some centers, especially in the US, are reporting that 50% of potential donors are actually obese. We've talked about the medical complications, the risk of developing all of those cardiovascular complications, and also the end-stage renal failure risk, and also the mortality risk, and the differences in the registry data and the single center data. We've also talked about the surgical complications, minor risk, or the major complication rate seems low, but slightly increase in wound risk. However, in carefully selected donors, you can offer them supervised weight loss, but I actually really think bariatric surgery seems promising because you're actually doing a public health intervention, whether they donate or not. At least, all those cardiovascular risk of hypertension, diabetes might actually just get better for that person, and they might just live longer. So bariatric surgery actually seems promising for this group of people who want to donate. And I think we need to individualize risk. We need to take every case separately. So in the case that I've shown, where the donor is 70 years old and they're likely to have a good quality of life as a pair if the 70-year-old wife donates to the husband, and the risk is small, I think we need to individualize the risk. If someone comes in their 30s and they want to donate, I might think differently. So that's the end of my talk, and before you ask any questions, I will leave you with this, and thank you.